There are four types of shock. Regardless of the type, they have one thing in common, which is the blood pressure is low. How the blood pressure drops is going to happen in one of four ways. Now, patients can have more than one type of shock occurring exactly at the same time, and that will, of course, complicate the prognosis. But overall, when we say shock, it's a syndrome, meaning when they come in with symptoms of shock, we treat the shock based on the cause. So the first step, therefore, when patient comes in with very low blood pressure is to identify the type of shock that we're dealing with because the treatment is not universal. The only safe treatment you can administer to any of the four types of shock is oxygen. But let's say giving fluids, for instance, can be harmful if it is cardiogenic or even obstructive type. Okay, so let's look at the one of the four ways. Now, oxygen delivery to the tissues, also called perfusion, is only possible with a mean arterial pressure of 65 or better. You still remember the formula for MAP? 2 times the diastolic plus the systolic divided by 3. Okay. So if the minimum mean arterial pressure is 65 or better to perfuse all organ tissues, then a drop below 65 means what's happening to the tissues and organs now? They're dying. Okay. So there's tissue ischemia, there's tissue necrosis at the cellular level. Right? So that can be disastrous. So cells start dying. And when cells die, of course, what will accumulate whenever you kill something? Lactic acid, right? Then there's lactic acidosis that will cause further changes at the cellular level. Okay, so that will cause further toxins to be produced. More cells tend to die as the lactic acidosis worsens and potassium increases and everything else, right? So without treatment, blood flow to the cells, again, will cause a change in the cellular metabolism. So now the patient's body goes from aerobic to now anaerobic metabolism, further increasing lactic acidosis and then leading to death eventually. So let's summarize the four types into the elements of perfusion. So perfusion to be possible, you need three things to be functioning properly or to be adequate. One is the pump, which is your heart. Next is the blood volume. And finally, blood vessels. A failure of one or more can result into shock. If the pump fails, such as during an MI, for instance, so a massive heart attack, a valve disorder, or a fatal dysrhythmia, such as AFib with RVR, for instance, ventricular tachycardia, ventricular fibrillation, that can cause cardiogenic shock. So a heart attack would be a very good example of cardiogenic shock, which means this is direct pump failure. The heart itself failed. If the heart can't pump effectively, what happens to cardiac output? What happens to cardiac output? Drops. What happens to blood pressure? What happens to tissue perfusion? Okay. Now, there are also conditions wherein the heart will fail through no fault of the heart, meaning structures around the heart caused it to fail. If that's the case, we call it obstructive shock. This is therefore called indirect pump failure. The heart failed, but again, it's not the heart's fault. Examples here are tension pneumothorax, cardiac tamponade, mechanical obstruction or trauma, for instance. Okay. So those types of things, a massive pulmonary embolism. Okay. So anything that will increase pressure in the thoracic cavity, causing the heart to fail. Okay. So these are usually non-cardiac in nature, except maybe for cardiac tamponade. Cardiac tamponade, we talked about that last semester under pericarditis, a complication of pericarditis, wherein there's a buildup of large amounts of blood or fluid around the pericardium, constricting the heart, causing it to fail. So that is called obstructive shock. In both conditions, the heart failed. In one example, heart attacks, valve disorders, the heart failed directly. In obstructive shock, such as the examples I gave, tension pneumothorax, cardiac tamponade, or let's say massive pulmonary embolism, the heart failed, but it wasn't the heart's fault. It was caused to fail because of increased pressure around the thoracic cavity. We have to distinguish between the two because the treatment obviously is different, right? You can't treat cardiogenic and obstructive shock the same, okay? Because the causes are totally different, but the end result is blood pressure drops. Okay. In the case of a blood volume loss, particularly, let's say you have blood or fluid loss, you can imagine diabetes insipidus, for instance, or DKA, or any other pre-renal AKI causes. Okay, so anything that will cause loss of fluid or blood, that will include trauma of 30% or more of the body's total fluid volume, that can cause hypovolemic shock. And then finally, we have three examples of the third type of shock. Let's call it distributive shock. Because unlike the other three, cardiogenic, obstructive, hypovolemic shock, what is the body's response once blood pressure drops, blood volume drops, oxygen levels drop, sodium levels drop? What is the automatic response? What will those stimuli I mentioned trigger? What will it trigger? Yes, all three results in inadequate tissue perfusion because blood pressure is low, oxygen levels are low. So therefore, what will it trigger as a compensatory response automatically? Sympathetic response, correct? There will be stimulation of the sympathetic nervous system, automatic release of epinephrine, norepinephrine, adrenaline. causing what to the blood vessels?
Constriction.
Vasoconstriction. Here in three conditions under the distributive type shock, there is no vasoconstriction. What you have instead is vasodilation. What is the effect of vasodilation on blood pressure?
Dilation decrease.
It will drop blood pressure, correct? So this is what's happening during anaphylaxis. So when we have anaphylactic shock, it's also the same thing during neurogenic shock, which is exclusively found in spinal cord injury patients, and then finally in septic shock. So in these three conditions, you don't have sympathetic vasoconstriction. What you have here, because of a unique set of circumstances, what happens is there is generalized systemic vasodilation. As a result, when all the blood vessels in the body dilate, what happens to vascular resistance? Is there any resistance?
No.
No. So therefore, no matter how high your blood volume is there enough pressure generated to move that blood volume throughout the body? No, no matter how high the heart rate becomes, as long as there is no vascular resistance because your blood vessels are so huge, it will drop blood pressure. Okay, there's simply no pressure generated. Okay, so we'll discuss more in detail, but here's your overview of shock. Okay, this one of four things will happen. Either the patient will have direct pump failure, indirect pump failure, lose fluid and or blood volume, and then finally have one of the three distributive shock, sustain anaphylactic, sustain spinal cord injury, and then develop neurogenic shock, or get COVID or any other serious infections leading to sepsis. Okay, and then end result will be septic shock if untreated. So here they are, back to page 274. So we've got the four types. We have here distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. All right. Any question? All right. So we know oxygen is vital. So this is a perfusion problem. This is the most serious of all perfusion problems. There is anaerobic metabolism here, absence of oxygen means no oxygen, no ATP, no energy for any cell in the body. You can read the details on your own. I've already explained the general mechanism. And this section here tells you about the body's response. And I explained that it is the sympathetic nervous system stimulation. And will there also be RAS stimulation, renin, angiotensin, aldosterone system? Okay, so we assume that is also happening because RAS and sympathetic nervous system have the same triggers, which are again one of the five: low blood volume, low blood pressure, low oxygen, low sodium, and low blood glucose. The stages of shock is essential to be identified because this will determine one of two. One, it will determine the severity of the patient's shock, and will also determine the level or the aggressiveness of the interventions we need to employ. Okay, so it's important to identify what stage the patient is in. Now, other textbooks, other authors identify an initial stage. This author did not add an initial stage. They went directly to the first stage, which is compensatory, followed by progressive. Progressive stage is also called No, sorry. The compensatory stage can also be called the non-progressive stage in other textbooks. So either on NCLEX that will appear as either non-progressive or compensatory. That's the same thing. Okay, so that's stage one of shock. By the term compensatory, what's really happening here? Compensatory. So what's happening during this stage? Okay, so the manifestations are brought on by what are those two responses again? When blood pressure, blood volume, oxygen, sugar, or sodium drops, sympathetic and renin-angiotensin-aldosterone system. So those two responses by the body, you can also add their antidiuretic hormone that will also be released, will be responsible for the patient's symptoms, which are, we'll look at the table, okay? And then, so as the patient goes from one stage to the next, what will cause the progression of the stage from bad to worse is, of course, ineffective treatment or non-treatment, meaning the patient had no idea that they're already going into shock. Okay, so that's non-treatment. Or let's say in the case of um, whether it's a heart attack or trauma or a severe infection or anaphylaxis, for instance, whatever the underlying cause of the shock is, it was not treated, okay, or it was not responding to the treatment. So that will bring the patient to the next stage, which will mean the signs and symptoms are getting worse. Once the patient enters the irreversible stage, very few people come back if they reach irreversible, because at this stage, you remember DIC? Okay, so DIC, what were the causes of DIC? Okay, one of the causes there was shock. Okay, so including sepsis. Okay, so any type of shock can cause DIC. So on top of the shock and the underlying conditions leading to that shock, the patient now develops DIC, which, as you know, whichever group presented that had a very high mortality, correct? Was almost impossible to treat DIC. And to make matters worse, the patient also develops ARDS. ARDS will be discussed later under gas exchange module. That's module 6. Okay, but the same processes, the same mechanism occurring in sepsis, particularly severe sepsis stage, and ARDS are the same mechanism. Okay, so overall, we can call these responses that lead to the irreversible stage complications, which are DIC and ARDS, as self-destructive um, responses by the body. There's no way we can stop it. That's just how our body works. Our immune system kind of panics and then responds in a self-destructive way. So let's start with the compensatory stage. As already mentioned, these are made possible, or the mechanism responsible for these manifestations are the patient's compensatory mechanisms, which are sympathetic and the renin-angiotensin-aldosterone system. So the two main processes of increased heart rate caused by epinephrine and vasoconstriction caused by the same, as well as renin-angiotensin, uh, causes the the fight or flight manifestations. And describe fight or flight. How do you feel when you are in fight or flight? You're nervous, right? Yes. So you're nervous because your heart rate is very fast. What happens to your respiratory rate? Okay, so you're hyperventilating at the same time. What happens to your skin color and temperature? You, are you flushed when you have vasoconstriction? You have actually pallor, right? And then how does the skin feel? Very cold and clammy. Okay, so those are again caused by vasoconstriction. Okay, what happens to the urine output? Decreases. Why? What's responsible for that? The aldosterone, correct? Okay, so the aldosterone was released, causing water and sodium reabsorption. So the fight or flight response, again, the effort is to shunt blood to the three vital organs, to the brain, heart, and lungs only, leaving the rest of the body, GI tract, kidneys, everything else as expendable. Okay, so only the three vital organs will be prioritized with blood flow. Everything else will have very little to none. So here again, so all the non-vital organs will receive very little to no blood flow. So that's why the skin is pale, bowel sounds are hypoactive, urine output drops. So let's summarize our manifestations here, table 11-1. So here you see the progression from compensatory to progressive to irreversible. And I repeat, once the patient reaches the irreversible stage, we typically start receiving calls from Live On New York. Do you know what Live On New York is? They're the organ procurement organization. Okay, so they have offices. Of course, they have a central office, but they have a representative in every hospital. They're given one small janitor's closet size office. Okay, so that's where they work, and all they do is watch for potential organ donors, which again includes the shock patients. So when these patients come in and then they enter or exhibit manifestations of irreversible um, manifestations, a state irreversible stage of shock, they start calling you. Okay, they're not gonna say, okay, kill the patient. No, of course not. They're just gonna ask for what's the latest vitals, okay, because they're trying to see if there are organs that can be salvaged. Okay, because eventually they know this patient will not make it. Okay, so they call you at least twice a day, whoever the nurse in charge is, and they'll just answer the questions. Okay, they'll just ask you for data, um, and then ask for the patient status. The patient doesn't have to be an organ donor. They already know what to do. They'll call the family, talk to them. They know they have a script, okay, to read. They know what to say, right? So you don't have to deal with that. So here are the manifestations. So in compensatory stage, doesn't mean the patient is not in danger. They are in shock, but at least the body is still compensating, meaning we still have epinephrine, okay, we still have renin, angiotensin, aldosterone system intact, okay, we still have ADH. The body's trying to maintain perfusion, okay? So blood pressure is still normal. However, when it reaches progressive stage, now the patient's blood pressure, systolic blood pressure, drops below 100. MAP is now at or below 65. So obviously here in compensatory, the patient's blood pressure is way over 70 here. Okay, but here, once they enter progressive stage, patient's blood pressure is now at or below 65. So just barely perfusing vital organs. In irreversible, no more. They're already in ICU. Okay, they have vasopressors running. They have invasive cardiac support devices already to maintain perfusion. Some of them will probably be on ECMO already, meaning external oxygenation. Here, and for the heart rate, under compensatory, heart rate still already over 100, but under 120. Here in progressive stage, the heart rate is already 150. Once they reach irreversible, it's really unpredictable. Okay, very irregular heart rate. Can be low, can be high. Respirations here over 22 in compensatory and progressive extremely in distress. Okay, so that's why you'll see here most patients coming from the nursing homes, they come in for sepsis. The main complaint at the nursing home is the patient has decreased level of consciousness. They have low oxygenation level. They have low blood pressure. Okay, so the underlying cause is usually they had pneumonia or UTI or an infected wound somewhere if they have a pressure injury, for instance. So that's the scenario. So nursing home staff don't always find pneumonia, especially in the elderly, because they don't present the same way. You've learned that, right? In fundamentals, UTI specifically. So they only manifest very subtle manifestations. And the first complaint, again, why they call 911 is the patient is now in respiratory distress. Why is that? They're already in the progressive stage of shock. They're already in shock, okay, but still in the progressive stage, meaning, yes, this may have been happening, but is this readily observable? I mean, is there really close monitoring for all patients in a long-term care facility? Not much, right? No, not much, because what's the ratio from RN to patient? It's like 1:20, right? Or at night shift, it's 1:40. Okay, so you can see the lack of close monitoring. So when they see the patient's already in respiratory distress. So that's not always caused by a respiratory problem. It's actually a cellular level condition. Okay, so the patient is now in shock. And here in irreversible, patient cannot be, the oxygenation needs cannot be met unless they are intubated already. And skin, of course, there'll be a little bit change here. You'll see the difference, but in the three types of all other types of shock, obstructive, cardiogenic, hypovolemic, even anaphylactic and neurogenic shock, they follow the same pattern, except on the first stage. Because there is vasodilation in anaphylactic, neurogenic, and septic shock, what will their skin feel and look? Because there is vasodilation there. Will there be cold, clammy skin? So, okay, they will actually be flushed and warm. However, once they reach the progressive or irreversible stage, that's when they turn pale. Okay, so it's initially, they will not look cool and clammy at all because there is vasodilation. So it's kind of weird in those three distributive types of shock. But in all, here you have decreased urine output. Then meaning you have oliguria here. Here you also have oliguria. However, in irreversible, there's now anuria. What is oliguria again? Less than 400 per day. This one, 0 to 100. Okay, so less than 100 per day. In all, there is mental status changes. So in compensatory, patient may be confused. Again, lack of oxygen here can cause confusion. There's lethargy now in progressive stage because the oxygen levels drop further. Okay, they're already in respiratory distress, and then unconscious here because there is zero oxygen here in irreversible. And in all of them, there is acidosis except in the compensatory because there is increased heart rate here. Increased heart rate and increased respiratory rate. So this will cause respiratory alkalosis, right? But that is only during this stage. This will not be sustained because, of course, as the patient progresses to the progressive stage, then there is now increased lactate levels. So therefore, they're already in acidosis. Management, as I said at the beginning, is the only safe administering intervention you can administer to all types of shock, regardless of cause, is oxygen. That's it. The next step is toward you have to identify the type of shock. Okay, that's the next step. After giving oxygen, starting IV access, you need to know what type of shock are we dealing with here. So we need fast diagnosis. So multiple blood work will be drawn, again, based on because the ER physicians already know that these are the 4 possible types of shock. So each patient that comes in with low blood pressure will be evaluated for all of these. So we'll draw blood to see if it's a heart attack. You get an X-ray, whether we're dealing with some thoracic issue. Okay, so maybe a PE or okay, so patient will be sent for a CAT scan. Blood work for heart failure, or let's say troponin, for instance, okay, to rule out. And then we'll do CBC to see if it's a dehydration problem, or depending how the patient presents. So if the patient looks flushed, for instance, and warm, then that's possibly distributive type, okay, or septic. Any questions so far?
Is no lactic acid?
Mhm.
Or lactic acid?
Yes, lactate levels will also be drawn. ER physicians, let's go to the diagnostic. Okay, we'll get there shortly. Again, oxygen will be given. Fluids cautiously until we rule out cardiogenic causes, because again, that will cause further heart failure if we give too much IV fluids, if it happens to be cardiogenic or obstructive shock. So blood pressure monitoring, close BP monitoring, especially the mean arterial pressure, will be done throughout the therapy, throughout all stages of shock. If needed, the patient will be, if severe enough, the patient will go into ICU, and they will have a pulmonary artery catheter inserted to determine hemodynamic status, meaning sometimes we can't get a blood pressure externally, and we cannot measure it in the arm or the leg. So we need a pulmonary artery catheter to measure blood pressure inside the heart. Sometimes it's the only way to measure the pressure. Our goal again is a mean arterial pressure of 65. At least 65. Is a blood pressure of 90 over 30 or 90 over 60 good or bad?
Well, it's not horrible. It depends. It depends on how, what is the patient blood pressure usually?
The answer is yes or no. Is 90 over 60, is that good or bad? What's the mean arterial pressure for 90 over 60?
The normal blood pressure is 120.
What is the mean arterial pressure of 90 over 60? I mean 80.
90 plus 90.
70. Right?
70 plus 90.
60 times 2 plus 90 is 210 divided by 3. It's 70. Yeah? Okay. So 90 over 60 has a mean arterial pressure of 70. Is that good or bad?
It's good.
It's very good. Okay. So is 90 over 60 good or bad?
Good.
It's good. All right. Okay. Now, understand also, we're talking about shock here. You understand? Of course, in other conditions, if this patient is not in shock, of course, we'll look at the patient's baseline, okay, and then decide whether 90 over 60 is good or bad, depending on the patient's baseline. However, when we're talking about shock, is 90 over 60 good? It's great, okay? We're very happy with that. So let's say it drops further to 88 over 59. What is it now?
It's good. No, it's not.
Well, calculate again, 88 over 59. What is your MAP? Because on its face, that looks bad. But what's actually the mean arterial pressure? 68. So is it good or bad? It's actually good. Again, in terms of a shock patient. Okay, are we clear? All right. Of course, the higher the MAP, the better. Okay, but are we happy with 68?
Yeah.
Yes, that's way above 65. All right. So our goal here, because again, this is a perfusion problem. So are we getting this patient out of bed? No, because we don't want any unnecessary energy expenditure, right?
Yes.
Because we're already having problems with perfusion here. We don't want to waste any more oxygen. Okay, so we'll conserve oxygen as much as possible so that the vital organs get perfusion, and hopefully also the non-vital organs are getting perfusion as well. Okay. So that's why, if needed, the patients will have to be sedated and put on a mechanical ventilator, right? If we cannot maintain adequate perfusion, so that's why you'll see sometimes when you're working on the floor, why are these people intubating my patient? Okay, the patient had no breathing issue. Okay, so why did we intubate them? Because this poor perfusion problem. Because we know that if the perfusion is low, automatically there is sympathetic stimulation, correct? And that will increase respiratory rate. Now the patient is working hard to breathe, and that requires accessory muscles, correct? And the use of accessory muscles, is that burning up more oxygen?
Yes.
Yes, so the patient is wasting energy. Okay, so we intubate them, right, to conserve metabolic demands. All right. Question one.
So, yes.
Oh yeah.
So, we were talking about intubation. How do you know that the patient don't need intubate, like the patient don't need to be intubated no more? That the vitals reading on.
Okay, we'll get to that when we get to module 6. Okay, 'cause that's a long story. Okay.
I have a quick question. Is
Mhm.
shock the main reason for using the mean arterial pressure? Because I always see it there, but I don't.
Not necessarily. It's for any cardiac patient, not necessarily in shock. So uh we 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 make it we use it as a basis for whether or not, again, on its face, whether or not organs are being perfused. So if it's 65 or better, we know that yes, cells at the cellular level, organs are getting oxygen. Okay. Meaning it's the minimum pressure needed. Okay, let's discuss positioning. So regardless of the type of shock, what is the proper positioning to maintain perfusion? Is it the one on the left or the right? What do you call the position on the right? Trendelenburg is if it's all low. The head is low, but the head is flat. Okay, this is modified Trendelenburg. So on the left, that is semi-Fowler's, correct? So on the right, that is called modified Trendelenburg. So instead of raising the head, you're raising the legs and the feet. So how does this benefit perfusion?
Brings blood back to the heart.
Okay, increases venous return, meaning promotes return of peripheral blood back to the heart, right? Because otherwise, if they're in this position, blood would struggle to return to the heart. Okay, so modified Trendelenburg promotes. You've probably seen this in emergency tents. Let's say if you've ever been in a marathon, for instance, and there are tents there, first aid tents. Okay, so people collapsing, what position do they put them in? Modified Trendelenburg. So they raise the leg, put it up on a stool or a pillow, for instance, okay, to increase blood return. And then all of a sudden, the patients wake up. Okay, first when they're found unconscious, and then once you raise the legs, suddenly they wake up. All right. So a simple positioning intervention improves perfusion by increasing venous return. Reducing anxiety. Again, anxiety will not help. Is this scary? Yes, this is scary for anybody. This is life-threatening. So of course, the patient will panic. Once panic sets in, that's further increased heart rate, increased respiratory rate, increasing oxygen consumption. We don't want that. Okay, so if needed, we'll have to sedate the patient if safe. If not, we'll just give them, a small dose of anti-anxiety maybe. Okay, but the goal here is rest. Okay, reducing oxygen demand. Clarifying advanced directives. You can do this at any stage, not necessarily in the irreversible, because we need to know and prepare for the worst. If this patient does not survive shock, what do we do? Okay, because we need to be prepared. So if this patient codes eventually, do we bring them back or not? Okay, doesn't mean we don't treat the patient. Don't get me wrong. Are we clear? So clarifying advanced directives, this is simply if this patient's heart stops or goes into VFib, for instance, do we do chest compressions or not? Do we intubate the patient? Well, your yes or no answer depends on whether or not their advanced directives say so. All right, so we need to know. Are we clear? Okay. And I've already mentioned, right, that this is part of your assessment when patient comes in the ER. This is one of the first questions you'll ask. Okay, do you have any advanced directives? Okay. We need to know. Please also understand advanced directives can be changed. You understand? So even if the patient has a signed DNR, can they revoke that? Yes, yes, the patient can revoke that, or the designee, whoever has the power of attorney, for instance, they can revoke a DNR. In such cases, even so let's say we have a DNR in place, right? But then there's an aggressive intervention that will cause death, because we will potentially cause death, maybe, meaning if we do a procedure that has death as one of the complications, the patient would be asked to revoke the DNR first before we perform the procedure.
Okay.
You understand why though?
Yes.
Yeah, because because otherwise, if don't revoke it, then no, there's a legal
So if they
thing
say
here.
that
Yeah.
she's not elected no realty, what you do?
Well, in the first place, we need consent before we do a dangerous procedure, right? Anyway, so that's a side, topic. So in New York, we have MOLST. Okay, so New York State has MOLST. That's medical, or in this case, physician order. It's the same thing. Okay, so either medical, for New York State, it's medical order of life-sustaining treatment. So this is a 4-page, well, it's back to back, so it's technically 4 pages. It's a bright purple document. You can't miss it. If you see one, oh, that's a MOLS. Okay, and that's exclusively for New York State. So look for those. Okay, if the patient has one, because that will specify what does the patient want in the event of a life-ending condition, and do they want CPR? Do they want to be intubated? Do they need feeding tubes? If they do need treatment, do they want aggressive or just fluids or antibiotics? Whatever. It's very specific. It's just check boxes. Nothing, patient doesn't need to write anything. Okay, it's just check boxes of whatever they want. But again, keep in mind, they can revoke this at any time, right? And then they can reinstate it as well also. So there's plenty of forms, so it just takes a few seconds. And doesn't need to be notarized. Okay, so this document is legally binding, okay, anytime the patient signs it. So safety here, the patient will have several IV access here. So they'll have at least two large bore IV access. Once in ICU, they will even get a central line, okay? Because we will need multiple medications here, and one IV access is never enough, okay? So we need two or more IV access, which is hard to do because remember, there's vasoconstriction. Can you even dilate? Can you distend these blood vessels? No, blood pressure is too low. You can't start, okay? So it can be challenging. All right, so once the patient enters the progressive stage, now here the map now is at or less than 65. So we can do all the heroics during this stage. Okay, so whatever aggressive measures you can do to help this patient, this is the time to do it. Okay, this is your last ditch opportunity, okay, to do that. So here at this stage, all organ systems are already hypoperfused for a considerably long time. And yes, they're still compensating, but these efforts are failing. Okay, so that's why the patient goes into severe lactic acidosis, which is metabolic acidosis. The potassium levels here start to rise as well, uncontrollably. So you need to address the hyperkalemia as well, which again causes them to have possibly cardiac arrest. Okay, so this is usually caused by hyperkalemia. Hyperkalemia and acidosis always go together. So when you have a patient in severe lactic acidosis, you can expect the potassium level will also be high. These are all brought by anaerobic metabolism, okay, because of the lack of oxygen. Thank you for reading, Miss Unique.
Even if the underlying cause of the shock is reversed, the sequence of compensatory responses to the decrease, the sequence of compensatory responses to the decrease in tissue perfusion perpetuates the shock state, and a vicious cycle ensures.
Okay. So what do you understand by a vicious cycle?
It's just keep getting worse.
Yeah, it just keep getting worse and worse. But again, the patient here still has a chance for survival. So with adequate treatment and watching for the early development of DIC and or ARDS, okay, so we can still bring the patient back. So here are the manifestations. Now I know we had table 11-11, 11-1, but that was a very flimsy table though. So I will still get the manifestations based on the paragraphs, okay? Because the table, let's go back to the table. See how flimsy this table is? So just use this as a general guide, okay? Because your details will be as far as, what's the blood pressure, what's the MAP, they're more detailed in the paragraphs in each stage. So as I mentioned, early DIC begins during the progressive stage. So here on the effects on the bone marrow, on the blood, clotting cascade is activated. So now you still remember ADIC? Starts with microvascular clotting, right? Generalized microvascular clotting followed by bleeding. So these are our goals. Again, continue to support the oxygenation, perfusion. So we'll have many medications ordered here now. We have vasopressors, we have fluids. There are support treatment as well. So what's the use of insulin and H2 receptor blockers here? The answers are here. So why do we our target here, by the way, once we have a patient in shock, is less than 180. Why not less than 110? Because it's not realistic. Okay, so the combination of cortisol, the stress hormone, as well as the organ failure. So once the blood perfusion drops, what happens to perfusion to the pancreas? What happens to insulin production? What happens to sugar?
Well, no, it increases, sorry.
Okay, so insulin drops, so sugar rises. Okay, so there is hyperglycemia in shock. All types of shock will have hyperglycemia. And what will that do to perfusion at the cellular level? So the higher the blood sugar, what's the thickness of the blood now? Even thicker. Okay, even thicker. So what happens to perfusion? Makes it worse. Okay, so therefore, a goal is under 180. So that's the purpose of this. And what's the purpose of H2 receptor blockers or PPIs? Okay, again, same thing. There will be severe acidosis here because this is very stressful on the body. So patient is at risk for GI ulceration and bleeding. By the way, this does not only apply to shock. All right. So any patient, therefore, who is very, very sick, blood glucose will rise. Okay, that's a natural response. You guys have also experienced that, right? Toward the end of the semester, your uniforms start getting tighter, right? They shrink. The uniforms shrink during that time. Okay, so again, this is our target. As I mentioned, this does not only apply to shock, but also you'll see the same in, let's say, cardiac patients. So PCI, bypass surgery patients, any critical patient. This is our target. Okay, below 180. Although we did not discuss it in this chapter, again, assume there is hyperkalemia. So you still remember your hyperkalemia management last semester? First week, a semester ago? What were those 5 interventions for hyperkalemia? Okay, please review them, all right? It's testable here because complications in shock is hyperkalemia. So once lactic acid levels rise, potassium will rise with it. And because these patients are intubated and on a mechanical ventilator, there will be a high risk for ventilator-associated pneumonia once they hit 2 days or longer on a ventilator. We'll test that later, but these are your bundle. Bundle is a protocol, okay, to treat or prevent something. So our bundle for preventing ventilator-associated pneumonia are the following. 2 are missing here. Number 4 and 5 are DVT prophylaxis and PPI. Okay, but the other 3 are oral care, frequent oral care, 30 degrees, have the bed elevation, and Oh, suctioning. Okay. Since these patients are mostly unconscious half the time, so you're actually just dealing with the family. Okay. So yeah, of course we talk to the patient, but they won't respond. They're either unconscious or lethargic. So your problem would be with the family members, and they talk a lot. Irreversible stage, there's not much to talk about here because the patient is on their way out. They usually don't survive because of, again, there's DIC already here. There's already ARDS. Once there's ARDS, it's impossible, close to impossible to oxygenate the lungs because the lungs are very wet. So all you can do here is typically keep the patient comfortable, depending on the patient's advanced directives, what to do at this point. Okay, whether or not the family wants further heroics or just let the patient pass peacefully. And I already mentioned organ donation. So again, at this stage, distraught giving families may interpret this as a chance for recovery when none exists. Okay, especially in the severe sepsis stage, which is about equal to the irreversible stage of the other types of shock. I mean, you understand, right? When somebody grieves, what's the first stage? Denial. Okay, so that's what you'll see, okay, in the family members, denial. So there's followed by what's the next stage? Anger. Okay, so what will they do at the nurse's station? Crash around. Okay, and this is nothing personal. Okay, this is just natural grieving. Okay, some patients will have first, it's always denial. Okay, there must be something else we can do, right? Things like that. No, can't be happening. And then start getting angry, sometimes physically. Okay. And when our they'll eventually get to acceptance whenever that is. Okay, let's go to general management, and then after the break, we'll go into specifics. So in all types of shock, this is our general interventions. As already mentioned at the beginning, oxygen, and then fluids, if appropriate. Vasoactive are also called vasopressors. So these are vasoconstrictors. So the most commonly used drugs are norepinephrine. You probably heard the term. It's probably more mentioned on its brand name, which is Levophed. Have you heard of that?
Yeah.
Okay, so Levophed is norepinephrine, or sometimes doctors will prescribe phenylephrine. Okay, so all of these are sympathomimetics. Okay, all vasoconstrictors. Okay, so why is there vasoconstrictor administration again? Okay, so to raise blood pressure, right? Keep in mind though, as you raise blood pressure through vasoconstriction, what happens to the cardiac workload if you constrict the blood vessels? It actually increases cardiac workload, right? Okay, so side effects of vasoconstrictors or vasopressors, of course, will be dysrhythmias. Okay, so watch for ventricular tachycardia, things like that. Okay.
Also, they're using or cardiac anesthesia.
No, we don't give we can give not vasopressors during the acute episode. No, we don't give that during the acute episode. In fact, we give vasodilators, right? We give nitro. Yeah. Okay. Okay, fluid replacement again, if appropriate. Okay, so exceptions here are cardiogenic and obstructive shock. Okay, But all types of shock can receive, all other types can receive fluids. The fluids given here is usually NS, usually normal saline. We try to avoid LR unless the patient has a hypovolemic shock from trauma, then that would be an exception. We use LR in that situation, but most commonly we use NS. You guys are aware there's a IV fluid shortage, right?
Yeah.
Okay, it's still ongoing. Okay, 6 months after the hurricane, we still have a shortage. We just can't keep up. Because it was a big facility in North Carolina. That was a third of the country's IV fluid supply was from North Carolina, that facility. They're back up, but there's a backlog, so we're still trying to keep up with the backlog. So you'll notice in hospitals, they don't have much stock. They only have a few bags because they have to this ration it throughout the whole hospital.
So that means they can always know.
Yeah, there's a strict rule on if the patient doesn't need it, don't order IV fluids. Meaning if the patient can drink, let them drink. Okay. All right, colloids as needed. This will help raise blood pressure as well. When we say colloids, these are blood products. Okay. Please be careful. Because these fluids are given fast and in large amounts, like 1 liter per hour, for instance. So what could go wrong there? Fluid overload, especially in the elderly, or if the patient, because remember, are these patients in AKI as well?
Yeah.
Can shock lead to AKI?
Yeah.
Yes. Okay. And then chapter 11 is only talking about shock. Okay. So it won't mention that this patient is also in what type of AKI? Pre-renal AKI. Okay. And it's not mentioned here, but they have that problem at the same time, right? But AKI, of course, is discussed in a different chapter. We discussed that last semester. But keep in mind, yes, this patient is in shock, but also in AKI. Are we clear? So that will complicate things. Okay. And of course, if needed, if we cannot drop the potassium here, patient will be on dialysis, etc. Okay, but again, it's not mentioned here. Okay. I mentioned ARDS, right? So the cause of ARDS is acute lung injury. Again, we'll discuss this later in module 6, but acute lung injury is the underlying mechanism that leads to acute respiratory distress syndrome. ACS, this is not acute coronary syndrome. This is abdominal compartment syndrome. Okay. So this is a complication again of large fluid administration. So complications besides the fluid overload, okay, of course, is pulmonary edema, meaning heart failure, then acute, abdominal compartment syndrome. I already mentioned earlier, the patient will have, when we say CVP, this is a central venous pressure line. This is basically a arterial line. Okay, arterial pulmonary artery catheter, sorry. Because we need to see the internal blood pressures. Okay. So central lines, the pulmonary artery catheter, our pulmonary artery catheter is a central line, obviously, because it's inserted into a central vein. Keep in mind, these are portals of entry, okay? So you must take care of these invasive lines. You can have a different problem, no complication, central line associated bloodstream infection, and that's another issue you'll have to deal with. So if the patient survives shock but then dies from CLABSI, okay, does that make any sense? So this is already mentioned earlier, vasopressors, so vasoactive medications or sympathomimetic drugs. So you got norepinephrine, phenylephrine. What do we monitor again with these types of drugs? Because they have the potential to increase cardiac workload, right? So watch for dysrhythmias. And also the infusion access. Ideally, these drugs should be given through a central line, okay? However, majority, because this is all an emergency, these patients will start with norepinephrine or phenylephrine through a peripheral line. Just make sure though that they don't infiltrate because their extravasation should be mentioned here. Right here. So because infiltration and extravasation of these drugs can cause tissue damage. And then now you created another problem. That'll be a chronic wound now on the patient. So again, all of these, our target MAP is what? 65 or better. Oh, one more thing. Vasopressor should never be stopped abruptly. If the doctor orders it off, meaning the patient's blood pressure is okay now, it's above 70, above 80, so it's time to stop, taper it. Okay, so usually we taper down by 10 or 20 micrograms per hour. Meaning, let's say you're at no, sorry, not 10. 2, sorry, 2. So let's say the patient was at 8 micrograms per minute, right? So you taper by going by 2 increments. So you go 6, 4, 2, and then eventually stop. Okay? Every hour. Because otherwise this will cause a sudden drop in blood pressure, which doesn't make any sense now. These patients will have short-term nutritional support. So we'll insert NG tubes, okay, not really PEG tubes because we don't expect this to be long-term. Don't forget to feed the patient. We try really to avoid parenteral because parenteral nutrition, again, requires a central line, which means we have CLABSI again or CRBSI. So we try to use the GI tract as much as possible. We already did CLABSI discussion in our second week of lab in 241. I won't repeat that. Okay, and then we'll end here for the break. These are the drugs we use to raise blood pressure. So these are your vasopressors. Between these, it will be either dopamine or epinephrine. Epinephrine comes in phenylephrine. Then we've got norepinephrine. There's phenylephrine. And if the patient has cardiogenic shock, then it'll be nitroglycerin. All right, take your break. Come back at 1:05.